So I want to start with my summary. Not to say that the talk is over, but just to let you know what I'm going to get to by the end of this talk. So basically I want to say that point-of-care ultrasound is an ideal modality to assist us in making clinically important decisions in a timely manner when dealing with critically ill patients. So let me try to show you how I've come to such a conclusion. Let's start with some cases. Let's say you're working at Vic, it's late at night or early in the morning, you're there by yourself, a couple of ambulances roll in at about the same time and bring two sick-looking patients. The first, case one, 57-year-old male. He's pale, diaphoretic, confused. These are his vital signs. Temp 38, heart rate 104, rest rate 26, BP 82 on 40, static 94% on a non-rebreather. He's not looking too good. So of course, it seems very non-specific at this time. You don't have a lot of information. There's a lot of things and thoughts swirling through your head. But it's quite clear that this person is in shock. They have low blood pressure. They're not mentating, likely not perfusing their tissues, all those sorts of things. And so I'm going to go through a little bit of a differential of shock. This talk is not meant to be about shock. This is not an all-inclusive differential that I'm going to put up here, but it is going to highlight some of the things that we can look at with ultrasound very quickly. So you have hypovolemic shock. So did this patient have some trauma? Do they have free fluid in their belly? Do they have a AAA that's leaking? Are they leaking somewhere else into a big pleural effusion or third spacing? Hypovolemic is a big cause of shock that we can evaluate. Obstructive, does he have a pericardial effusion, a PE, cardiac tamponade, pneumothorax? Distributive, all the vasodilatory types of shock like sepsis, whether it's early or late, anaphylaxis, that sort of thing. And then cardiogenic, has this patient had an MI? Does he have a cardiomyopathy? Is there a valvular issue? Something like that. So our current use of ultrasound is dominated by Eddie, and you'll all recognize the graphic on the top there, and on the bottom that's Ray Wiss and Steve Sokransky. They're sort of the godfathers of this whole Eddie movement. And we're very comfortable with that. We're very good at it. Drew has worked very hard, both behind the scenes and on the front lines, getting everyone trained up. I think we have 80% of the staff all trained up that are IPs. 40% of the residents are IPs, and the rest of them are going through and collecting their scans. So obviously we know our indications that we use Eddie for: free fluid, AAA, pericardial effusion, intrauterine pregnancy. We're very comfortable with those. We're good at those. And it hasn't come without growing pains. I mean, if you talk to someone in Emerge, any of the staff here, 5-10 years ago, what you would have done or what you would have thought of a 22-year-old pregnant female who came in bleeding at 8 to 10 weeks or so, someone handed you an ultrasound probe and said, "Can she go home safely?" You'd have looked at me like you're crazy, because you just didn't have that skill set. Same thing with an elderly patient coming in with belly pain. If someone handed you an ultrasound probe and said, "Do they have a AAA?" You'd be like, "Well, I'm not going to trust myself. I'm going to send them to the department or to radiology or get a CT scan or something." But over the past 5-10 years, we've developed those skills, and we can now say with confidence, yeah, this elderly patient has belly pain, but they do not have a AAA. I think in 5 years, I'm sure we'll be saying the same things about many other applications of ultrasound. So let's talk about some of those because in the States, they're quite a bit ahead of us in terms of their ultrasound. And I've just thrown up a bunch of studies here to show that there are different scanning protocols to rapidly determine causes of hypotension. And I'm sure some of these buzzwords are out there, and you've heard of the rush exam, the rapid ultrasound for shock and hypotension. There's several others. There's that have looked at using ultrasound for hypotension back in like 2007. There's an ACEs protocol that was developed by another group, looking at LV function, looking at IVC. So there's lots of research being done in the States, and this list is by no means exhaustive. There are other studies out there and lots of work being done. So I want to go through over the next little bit using this case and a second case as a template to go through how to approach a patient in shock using ultrasound to narrow down your differential diagnosis, which allows you to make important, timely treatment decisions. So I'm going to call it the sort of rush exam, but it's a modification of what the actual Rush publication advocates for, because they include things like DVT, which is a little bit down the road, I think, but there's a number of other things that I think we should get to first. So I'm going to present a bit of a modified version, one that Dr. Scott Weingard down in New York, who's a fellow colleague of Rob Arntfield's when he was down there, and he, on his website and on his blog, he's got the EMCrit podcast and all that sort of stuff. He has a sequence of going through the Rush exam that I think is very good. It's simple and relevant. And his sequence is HIMAP. That's the acronym. I'm not great with acronyms. They're not my favorite, but this one's not bad. So basically it starts out by looking at the heart. He says this is the most important part. This is where we get a lot of information. We can look at the pericardium, which we're pretty good at with our one view, but this adds other views. LV function, chamber sizes, contractility, thrombus maybe. I mean, obviously TEE is better for thrombus than transthoracic, but you get a lot of information looking at the heart, and he suggests starting there. Then sliding down and looking at the IVC. This is looking for fluid status, or basically the tank. So some of these studies look at it from a few different views. They look at the pump, so the heart. They look at the tank, like how much fluid is on board, and they look at the pipes, so things like like your aorta and whatnot. He suggests, after moving from the IVC and determining fluid status, to go down to the belly and look at Morrison's pouch and the splenorenal views. And we're already very good at those. We've done that with our Eddie. So it doesn't take a big jump to just tilt up a little bit further and have a look up at the pleura. And that will show us if there's a big pleural effusion there or hemothorax. And I'll show you some example of those shortly. Next is the aorta. So obviously looking for AAA. Again, this is already in our tool bag. Pneumothorax and pulmonary edema coming up to the chest, and looking for evidence of these. And I think Drew and Rob and myself, when we're in the department, a number of you have approached us to say, hey, can you show me this? I'm really interested in this pneumothorax thing, the lung sliding, all that sort of stuff. So we've started to show a few people, and I'm going to show some examples of that today. So that's the sequence. So we'll just go through sort of one at a time and have a look for our 57-year-old patient we've got sitting in front of us with undifferentiated hypotension. So these next slides are not meant to be an all-inclusive session on echocardiography. I'm going to introduce you to the common views, show you some anatomy, and some clips that will help assist with our case. So the first view I'm going to show you is what's called the parasternal long axis. So that's basically looking down, because the heart sits in the chest kind of like this. So it's looking along that long axis, and you're looking with your ultrasound beam that sort of cuts through the chest and cuts the heart in half this way. So you have the left ventricle here, and I think if you can see my mouse up there. Left ventricle, you can see the papillary muscles in there, chordae tendineae, the mitral valve leaflets. This is the left atrium. And then from the left ventricle, you've got the outflow tract through the aortic valve, the aorta up here. Here you've got the interventricular septum, and above it you've got the right ventricular outflow tract. And you'll be able to see the pericardium both here and here on the actual echo view. So I'm going to show you that next. What we've got here is, again, your left ventricle. You can see the mitral valve flapping away nicely there. This is the left atrium. Here you've got the left ventricle outflow tract with the aortic valve right there. The septum here, right ventricular outflow tract. Pericardium is this bright white area here and a little bit up here in the near field that you can see. And down here at the bottom, you've also got, I'll just move my mouse, you can see that that's the descending thoracic aorta. So I know you're not echocardiographers, none of us are, but that's not the point. But you can see generally that this heart is beating away nicely. There's good contraction. There's no areas of the heart that aren't moving. The mitral valve is opening nicely. Everything looks good. So that's a normal view, and that's what we would see. Let's say that's what we see in this patient of ours, the 57-year-old. The second view I want to show you is the parasternal short axis. So that's basically going from this longitudinal view, turning it 90 degrees, and basically getting a cross-section through the heart. So you see the muscular, thick-walled left ventricle here, with the septum separating the left ventricle from the right ventricle, which is this thinner-walled, crescent-shaped structure here. There's a number of different areas or levels you can look at. The one we're interested for assessing LV function is the papillary muscle level. So that's what these little nubbins are here and here. Those are the papillary muscles. Again, we'll be able to see the pericardium in this view as well. So let's try tilting that, overlaying it over an actual image as it plays. So you can see this is the left ventricle. You can see the papillary muscles there. The right ventricle is up here, this crescent-shaped area with the septum, pericardium down here. So in this view, you can see that the heart is contracting nicely. Everything's going towards a central area. The septum is nice and round. If you get overload of the right ventricle, you get some flattening of that septum over here, so it looks more like a D-shaped ventricle. But in this case, this is totally normal. Looks good. Everything's contracting nicely. The last view, or additional view that I'm going to show you today, because we're already familiar with the subcostal view, is the apical four-chamber. And this is the one that sort of it seems to be most familiar to people because it shows all four chambers, which is what we commonly associate with looking at the heart. This one's obtained by looking from down low up towards the shoulder this way and cutting the heart in half this way. So you have the left ventricle, left atrium, right ventricle, right atrium with the septum in between. So if we overlay that over an actual image and then play it, you see the same structures. So left ventricle, left atrium, right ventricle, right atrium, and the septum pointing up towards the apex. And again, you can see that in this view, it's important to look at the chamber sizes. So right ventricle compared to left ventricle. The left ventricle should always be larger and be taking up more of the apex than the right ventricle. And that's about as much as I'm going to say about that, because you can see that everything's contracting nicely. So basically, with these three views of this guy's heart, he looks like he's got a pretty normal heart. So I've thrown up some studies here just to say that these are all done in the early 2000s, and these just show that EP, or emergency physicians with limited extra training in echocardiography, can obtain good images and determine LV function accurately in the emergency department. So these are emergency physicians that had a little bit of extra training, and they obtained images, and they compared them, or they showed these images, they interpreted them, and then showed them to cardiologists, and had the cardiologists assess them. And the agreement between what the emergency physician thought and what the cardiologist thought were very good. In several of these studies, for example, in this one, they actually had a secondary comparison with that cardiologist against a second cardiologist, and the agreement between the emergency physician and the cardiologist was actually better than the cardiologist and another cardiologist. So it shows, there's lots of good evidence showing out there that we can do this. It's not something that we need to put up on a pedestal doing echocardiography. Again, we're not going to be echocardiographers. We're using it like we are a point-of-care ultrasound with Eddie in answering very specific questions about our patients in front of us. So that's sort of the take-home point there, is that we can do this. I just want to mention briefly at this point, I think, just since we're talking about echo and all that sort of stuff, a scholarly project that I'm working on, just one quick slide, a little plug, because it's going to be coming out probably shortly in the new year, with the goal to evaluate the effect of an educational tool designed for emergency physicians to discriminate broadly between categories of LV function. It's an educational tool, 15 to 20-minute online podcast tutorial. The design is going to be an online survey. You'll do a pre-test with some echo images. You'll watch the podcast, and you'll do a post-test. And we're going to assess, whether you improved, and hopefully you do, after watching the podcasts. And we're going to be using emergency physicians who regularly use bedside ultrasound, but have limited extra training in assessing LV function. And this is just sort of an important first step in getting us started and showing, that we are interested in this, and that not a lot of ultrasound research has been done in Canada, so I think it's a good place to start. So that's my plug. So let's go back to the rush exam. So we've looked at the heart, we've looked at the pericardium, LV function, all that sort of things. Looks okay. So let's have a look at the IVC for fluid status. This is an image of the IVC. So without going into too much detail, this is the right atrium, and that's the junction that we want to assess, is the IVC draining into the right atrium. This is all liver up here. And we're going to be focusing our eyes 2 to 3 centimeters from the aortocaval junction. And you can see that with respiration, as things are moving around, that you do get the sensation that there's some collapse there of the IVC. Another way to look at it is using M mode, and I know that's scary to throw out. You know, M mode is a second mode on the ultrasound machine, but basically it's the time lapse or the long exposure photography version of ultrasound. So you're taking all the echoes just down this one tiny straight line and displaying those pixels over time. So that shows you that, you know, all this stuff up here is looking through the liver. You get to the dark or anechoic IVC, and that's this area here. So you can see during expiration, the IVC is larger. During inspiration, you know, the thoracic cavity has negative pressure. The IVC drains its blood easier. So you can see in this case that there is, you know, around 50% variability in his IVC with respiration. And that has been shown to correlate to the fluid status of the patient. This study looks specifically at comparing it to CVP, and you know, CVP is not very good in and of itself in estimating total body fluid status, as Rob will tell you if you let him. But it just goes through and shows the concept that during inspiration, the IVC collapses. During expiration, it's nice and large, and you can correlate the patient's fluid status based on this. If they have a big plethoric IVC that doesn't vary with respirations, then fluids are probably not going to help you out too much in that case. Next is the Morrison's and splenorenal views. Obviously, we're good at these. We know these. I'll just throw up an image just for fun. But one thing that we can add to this very easily is looking up into the chest and looking at the pleural space, because here we can see our diaphragm, and on the left upper quadrant we look for that every time. And if there's fluid there, then it's quite obvious, because fluid is anechoic. It's going to be black. So in this case here, you can clearly see, you know, there's the echogenic diaphragm there, and then just above it there's a whole bunch of fluid. This little white or echogenic sort of flappy structure is atelectatic lung. Lung, as it gets compressed in the chest, starts to look a little more like liver or spleen. I think they call it hepatization or something of the lung as it gets compressed. But it's very easy to assess for pleural fluid or in this abdominal view. You can also look on the cardiac echo views, but this one is familiar to us and should be very easy for us to do. But this doesn't have this for our 57-year-old guy with a hypotension. This is not his. This is just an example of what it would look like. Next in the rush exam is the aorta. Obviously, again, very familiar to us. Just show a quick view of going down to the bifurcation there. We're already good at this. Lastly, we'll look at for this patient pneumothorax and pulmonary edema. And this takes a little bit of thinking about when you go to assess a lung with ultrasound, because we've been taught the whole time that air is the enemy of ultrasound, right? It doesn't go through air. Whenever we're trying to look at an aorta and there's air in the bowel, it ruins our exam, right? So how do we look at an air-filled structure like the lung to be able to assess it? And basically we do this through looking at artifacts. So normally artifacts are the enemy of imaging. So if you're looking at a CT scan and they've got some hips done or something, and there's, you know, bright lines shining through everything, you can't make out what you're looking at. Artifacts are generally bad with imaging. But in pleural imaging, looking for pneumothorax, it's actually reproducible artifacts that give us information about what's going on inside the chest. So there's a number of things we could talk about, but in the interest of time, we'll talk about just a couple. The first is lung sliding, and that's movement of the visceral pleura against the parietal pleura inside the chest. It's also called shimmering or ants on a log. So basically, this is the pleural line here. That's what we want to focus our eye on. That's our radiographic area of interest, as it were. So as you look down through, this is done with a linear probe. Again, you can see it's the square footprint, so the high-frequency probe. These are all subcutaneous tissues. This is pleural line. And I think you can get the sense that there's some shimmering, there's some movement, there's just a sensation that something's going on there. And this indicates that there's connection between those two layers of pleura. Perhaps it's best to just contrast that to a pneumothorax. So when air separates those two layers, you lose that contact and you lose that sensation of shimmering, or ants on a log, or whatever you want to call it. So here, this is the pleural line, and you can see that although there's some movement of the subcutaneous tissues, that shimmering really isn't there. So this is the one time I would change the probe. Some people do look at it with the cardiac phased array probe because it's got the smaller footprint and you can look through the rib spaces. But, and I've tried that, and some people like that. I prefer the linear probe, the high frequency. You don't have to look very deep in most cases, so this gives you the best resolution. So for our case here, his lungs were fine. He did not have a pneumothorax that we could see. And I should say that for these images, you can basically only say that there's no pneumothorax under where you're looking. So that begs the question, like, well, how much do we have to look? Do we have to look in every single rib space to exclude pneumothorax? Well, in hypotension, no. I mean, occult, this is so good that we're going to pick up some very small pneumothoraces, and not all of those are going to be clinically significant. We're looking for the big ones that could be a cause of his hypotension. So the scanning protocol that we suggest, or that has been suggested in the literature, is basically 2 points of assessment. You're looking up in the anterior, second to third rib interspace, mid-clavicular line, and then down laterally in the fourth rib interspace, anterior axillary line. So you're looking here and here on both sides and compare side to side. Look here and here, look both sides. If you don't see a pneumothorax, if you see good lung sliding, you're done. They don't have a big pneumothorax. That's not the cause of their hypotension. As an adjunct to lung sliding, there's a number of other things we could look at, but one I want to show briefly because a lot of people find this very intuitive is M mode again. So this is, again, taking those pixels down this line that's drawn down and displaying them over time. So the pleural line is here in both of those images, and above this is subcutaneous tissues. So this is all subcutaneous tissues. And then down here in a normal lung, you see this sandy beach sign. So this is indicative of contact between the visceral and parietal pleura. This is in contrast to a pneumothorax where you lose that sandy beach sign. You still have your pleural line that you can identify, but then you get what's called a stratosphere, or a barcode sign. If we compare those side by side, it's quite striking the difference between a pneumothorax and a normal lung, which is on this side. And this is the pneumothorax. So those lines just continue all the way down. So let's get back to our case. Oh wait, not quite yet, not quite yet. Let's look at just one quick study. This is hot off the press. It's just done in 2011. It's from a surgery paper. It's in trauma. But just to show quickly, I mean, the sensitivity of using ultrasound for identifying pneumothorax in trauma is 81%, almost 82, specificity 100%. This is compared to their chest x-rays. Again, these are supine in the trauma bay that are much more difficult to identify pneumothorax. Sensitivity is much worse. So there's lots of studies out there and evidence showing that ultrasound is much better. But again, we're looking for the big ones that could be a cause of their hypotension. So you do need to use your clinical judgment when you do find a pneumothorax. So let's get back to our case. So we've got our sort of abbreviated shock differential, things that we've gone through and looked at with our rush exam. So what can we say here? He doesn't have free fluid. He does not have a AAA. There was no pleural effusion or pericardial effusion. Doesn't look like he's got PE. We didn't talk about that specifically, but you'd see signs of right ventricular strain, which is an enlargement of the right ventricle, particularly on the apical four-chamber view. So it doesn't look like he's got that going on. Definitely doesn't have a cardiac tamponade. No pneumothorax. Late sepsis, you generally see a more dilated or a heart that's not functioning as well, decreased left ventricular function, so it's probably not late sepsis. And cardiogenic, I mean, his heart looked pretty good on our images. So, with about a 2-minute protocol, and that's what this should be designed to do. I know I was listening to one of Scott Weingard's things, and he says in an experienced hand, the rush exam should take about 2 minutes. So if we can take that much time while we're doing our other things, we can get a lot of information very quickly And then we can start appropriate treatment. So in this guy, you might want to start with some IV fluids and some broad spectrum antibiotics and start looking for a source. Continue down. Pardon?
It's likely malingering, is that right?
Well, possibly. And then you're going to go on and do your usual care, but you can confidently say he doesn't have all those things. Those are out of your mind. You don't even have to worry about them. So as we do this for this guy, you start some things. You're like, okay, good. So we've got a second patient that rolled in at the same time. So let's go through this one. We'll be able to go through it quicker because we've already gone through a lot of the sort of teaching thing. So this guy was brought in as well. Same time, 57-year-old male, pale, diaphoretic, confused. His vital signs are, as you see here, and looks very similar to the first patient, doesn't it? Yeah, they're exactly the same. I mean, it's just for fun. So let's see how this one plays out. So we'll go through the rush exam again on him, starting with the heart. So in this image, again, we've got the same structures. So this is your left ventricle, mitral valve. This is your left atrium, your left ventricular outflow tract with the aortic valve, aorta, septum, right ventricular outflow tract. Pericardium down here looks okay, no effusion there. But just if you remember back to the other one, I maybe should have put the normal one on here to compare, but it just looks different, doesn't it? I mean, it's a little bit dilated. There's not as much action happening. Those walls aren't contracting as well. The mitral valve is barely opening. You just get the idea that this heart is not normal. So if we look in the other views, this is the peristernal short axis. Again, the left ventricle is here. Those are your papillary muscles. You see a little bit of the mitral valve coming in there. The right ventricle is up here, your septum. Pericardium is the bright structure down here. So again, you see things are moving, but just not as well as the last one. And then if we look at our apical forechamber, left ventricle, left atrium, right ventricle, right atrium, septum. You can't see a lot, you can't see much of the free wall in this one, especially the way it's projecting up there. But you do get the idea, again, that there's global dysfunction. The heart is not beating as well. There's not as much happening there. It's harder to see up there, I think, but again, I can see that the right ventricle is not as large as the left ventricle, but just not contracting as well. So there's something definitely going on with this guy's heart. IVC, let's look at his fluid status. Just got one image here. So again, this is the right atrium. This is your IVC. This hepatic vein here is a very good landmark to use as a good place to do your measurement. And you can see as, excuse me, during respiration that there's not a lot of action there. The IVC does not look like it's collapsing, and it looks, big and plethoric, as it were. So putting it together, this guy's got a heart that's not beating very well. Tank looks like it's full. Let's keep going down our rush exam here and have a look at the belly. So this is another normal view. We can see the interface there is nice. Don't get drawn to the dark side, as Drew says, and look at these dark areas here. Those are just renal cysts, and those are of no consequence to us, so there's no free fluid there. Aorta, again, we'll just have a quick peek as we're sliding down. Looks totally normal, so that's not his problem. Pneumothorax, let's have a look at his chest. And this is a different view, so you can see here, these are ribs with rib shadows on both sides. And this is the pleural line here. And this one, you do get the sensation of sliding and moving, but you also have another artifact that we didn't talk about before, but that shows us that there is no pneumothorax, and those are B lines or comet tails. So when you see these bright echogenic lines basically extending from the pleura all the way down to the bottom of the screen that don't fade or anything like that, those are B lines. And those indicate that there is connection between the parietal and the visceral pleura. And if you can also use that to look for evidence of pulmonary edema. So if you have more than 3 of those B lines in any given rib space, that's indicative of pulmonary edema. And so this guy, has got at least 2, maybe 3. So maybe he's got a little bit of extra fluid in his lungs. So let's have a look through our differential for this guy. No free fluid, no AAA, no pleural effusion, no pericardial effusion or evidence of PE, tamponade, no pneumothorax. Doesn't look like early sepsis because generally you get a normal heart or a hyperdynamic heart. Could be late sepsis for sure, but I mean there's a few other things going on. There's some extra fluid in his lungs. His IVC looks nice and big, so we'll keep that on the list, but maybe not quite as likely. But definitely there's something cardiogenic going on here. I mean his heart is not beating well. There's global dysfunction. So whether he had an MI, he's got a cardiomyopathy. We're not sure at this point, but this you can see changes our management dramatically from the other 57-year-old guy. This guy, we're probably going to do things like positive pressure ventilation, maybe some inotropes, whatever. This is not a talk on treating shock. This is a talk on diagnosing it with ultrasound. So you can see that if we went through this differential, and I could have come up with any number of scenarios where we could have had, a pericardial effusion causing the shock. We could have had a pneumothorax. We could have had, AAA. All those sorts of things. I could have shown you quite easily in any sort of case presentation. So we have our ultrasound uses now. We're very comfortable with. An 80-something-year-old man or woman comes in with belly pain. The first thing that goes off in our head is let's get the probe on, look for a AAA. Same thing in trauma. We're going to do our exam looking for free fluid. Pregnancy, we're going to be looking for that intrauterine pregnancy. And the next step, I think, is looking in hypotension. So you have a patient that has undifferentiated hypotension. They're critically ill. This is a time that with a short exam, with a few extra skills to build on what we've done so far, we can make a big difference. So just to show you that this is not, I'm not pulling this out of thin air. This is a policy statement by the American College of Emergency Physicians that was published in 2008 on emergency ultrasound guidelines. And it's a 38-page document going through, the whole scope of practice, training, credentialing, QA, research, all that sort of thing. And they just outline what ultrasound means and how it should be used in the emergency department. And they have, so I just showed you our 4 sort of core indications for using ultrasound. They have 10 that they're comfortable with. That's what they train every single one of their residents to use. Their staff are trained to do this. And a lot of this overlaps with what we do. So the trauma, intrauterine pregnancy, procedural guidance. I mean, we do that sort of thing, AAAs, all that. But they've added in, a number of others, and I could have talked about some of these others as well. But I think the most important point to start with is probably the cardiac and thoracic images, because shock matters. I mean, those are sick patients, and those are ones we can make a difference in quickly if we diagnose it. So just to throw out a couple pieces of literature. I mean, there's lots out there, but just to highlight a few things. This was a publication from Shock in 2004. The objective was to test the hypothesis that more severe hypotension in ED patients will have worse outcomes. So basically, their worst outcomes they followed were like death, ICU admissions with and without organ failure. And their conclusion at the end of it was that the depth and duration of hypotension appears to have a dose-response relationship to adverse hospital outcomes. So that's not only how low their blood pressure went, but how long they were hypotensive for. That had poor outcomes. So shock is bad. How can ultrasound help? Has it been proven to help? I mean, I've shown you a bunch of images and what I think, but there has been a study done, and I think this was a pretty interesting study. This was done to examine the effect of using bedside ultrasound to identify the cause of non-traumatic hypotension in the emergency department. So an interesting study. They took if a patient came in with undifferentiated shock, it had to be decided by 2 physicians, et cetera. They were randomized at that point to either usual care plus the ability to use the ultrasound in the first 15 minutes, or usual care plus ultrasound use in 15 to 30 minutes. And what they showed, and then at the end of 15 minutes, they filled out a short sheet checking off what they thought the differential was, what the most likely diagnosis was at 15 minutes and at 30 minutes. And what they showed is that physicians indicated the correct diagnosis 80% of the time when using ultrasound in the first 15 minutes versus 50% of the time when using ultrasound in the second portion. So they were able to narrow the differential, and start appropriate treatments faster when ultrasound was used in the first 15 minutes. I gave you my summary at the beginning. I said that point-of-care ultrasound is an ideal modality to assist us in making important clinical decisions in a timely manner when dealing with critically ill patients. And I hope I've been able to share with you a little bit my passion for point-of-care ultrasound and how using point-of-care ultrasound in the critically ill has changed my practice. And I hope that we can move together as a group and incorporate point-of-care ultrasound and use it in our patient care. Thank you.